Thank you very much for this great opportunity to give that talk here. Actually, yesterday evening or yesterday afternoon at the same time, I was still running through the forests in Italy to look for truffles. So the small truffles with the rest of my family. And then this morning, I just got up at 6 o'clock to be here. But my topic is cross-linking refractive surgery. And being honest, I would like to go over three steps. In the first one, I would give you an information about the basics of cross-linking, what we know today. And then I would like to talk about cross-linking in surface ablation. How do we do this? And that's this part was decided when I saw that he is giving a talk about Contura. And then I will talk about cross-linking in LASIK, which is some more in-depth stuff. Sorry. Remember that cross-linking can be defined as a procedure that creates. Oh, I can't. Do we have a pointer here? Yeah. As a kind of procedure that creates radicals inside the cornea, and then those radicals create new chemical bonds between neighboring molecules. Not necessary on the collagen, because Mrs. Hayes in England made some X-ray experiments on cornea and saw that the new chemical bonds are not located only in the collagen molecule, but in the proteoglycans also. So it's not, and that's when we changed the word from collagen cross-linking to corneal cross-linking again. We start with corneal cross-linking, then it was changed to collagen cross-linking. Now we are back at corneal cross-linking because we learned it's not the collagen surface only that is cross-linked, but it's also bonds in between the collagen molecules over the proteoglycans. The second, on this kind of new bonds are creating a biomechanical action, which we can easily show in those stress strain measurements. This is a strip of a pig cornea, and then you can easily make the extension and measure the force that you need, and those are the curves, and you could see that a normal human or pig cornea has this strain of 1%. You get you need 4 megapascal, and here with crossing you need much higher force. So that cornea is stiffer and stronger, and that is one of the things that we see right after cross-linking. But there's also something that we are also getting, because cross-linking is not only a switch on, switch off stuff. So if you create a cross-link in the cornea, that cornea heals. And the healing takes 10 years, 15 years. And this is one of our worst cases where we started in 2005, see the numbers. That was 2006. Here, I was the hero of the patient because he was short-sighted and had astigmatism. And here, at 4 years after surgery, the myopia was gone and the astigmatism was gone. He was running around without glasses. And 5 years later, on a sudden, he was using glasses again, because meanwhile, this was 9 years after, he was presbyopic. He needed reading glasses and distance glasses because he turned to be hyperopic. Now, those healing processes occur only in about 5 to 8% of the cases, but they really are healing processes that continue. So have in mind that cross-linking is not something, but has consequences for years. It has also a biochemical action. The new bonds create the collagen as well as other tissue compartments in the extracellular matrix to make that more resistive against melting. So that is, by the way, also Mrs. Hayes, and she showed she was using corneal buttons from pig eyes and put them in pepsin and collagenase. That was eaten up right away within 6 days. If that cornea was cross-linked, it stays constant. So the enzymes creating melting of the cornea could not apply to that collagen anymore because there was additional bonds that the enzymes could not enter the collagen structure, and therefore you can make those corneas resistant against melting. We do have also a cytotoxic action that kills, oh, that was the wrong one, that kills cells, not only keratocytes, but you kill also germs that are inside the cornea, like in this case, this is, if you look at here, -5 microns, that is Bowman's membrane. If you go down 250 microns, you still cannot see normal keratocytes. They are killed. It takes 290 microns until you get the normal reflection pattern from the nuclei of the keratocytes. So we are killing everything down the road, and that was used in one of those cases, a patient with a melting disease after tuberculosis of the cornea. So there was a gutta first, and then it was melting. People could not get rid. It was tuberculosis after LASIK. They floated the interface twice, and the outcome was negative, as usual, with mycobacteria. And so, in essence, we couldn't help at all. And then we did the cross-linking. We killed all the mycobacteria inside the cornea and made the collagen resistive against melting. And that was 5 days after cross-linking. You see how this improved maximally. I did then a DALK a few months later. So that is the principle of our cross-linking. And now, how can we use that with the surface ablation? Now, this is a patient coming in, 32 years old, sees 0.6, uncorrect 0.5, so the glasses do not help very much, cannot use contact lenses. And now the bad news is he is a lawyer, and in addition, he is a diplomate from Ukraine. Those are the patients you try to stay away if possible, but this one insisted to get treated. And that's why we did a cross-linking first. And after cross-linking, it still looked pretty much the same, and did then a topography-guided treatment. So we did some treatment over the hill, not too much. Maximal ablation is 37 microns only, and we got rid of this astigmatism. Now you should know that I told the patient that I will make a treatment that makes him capable of using glasses to see well. It's not to make him, bring him in a position not to use glasses anymore. We have to, in this contour or topography-guided treatments, we would like to make a normal or regular cornea. And that was the purpose of this. And this is the, I think, see, 12, 17, 11. So it's a 3-month follow-up after the treatment. And you can see he came back to 1.0. And when I told him that if he wants to get rid of this astigmatism, he will need an implant, an ICL, he denied. He said, hey, I've got enough. I can see 0.8 now without glasses. I don't need to see better. And when he came back a year later, he still had the opinion that he doesn't need to see better. So in essence, the topography-guided treatment and cross-linking are two sides of the same coin, because you need the cross-linking in order to stabilize the cornea, otherwise she will not be stable. And on the other hand, you would like to smooth it out and get rid of the high-order aberrations. That is a lady who came in for myopia correction, and she had a form first of keratoconus. And because she had a form first of a keratoconus and was 36 or 37, so I said, hey, you never know today, even 37 or 40-year-old ladies can get children. So there was a clear potential of become pregnant. And you know, during pregnancy, the keratoconus usually advances because the baby has to get out of the belly, so and the connective tissue has to make flexible, stretchable. And of course, those hormones making that in the pelvis are coming up to the cornea also. And therefore, we published 2 years ago 6 cases where they had LASIK and everything was fine, and then they became pregnant even 9 years after the LASIK, and on a sudden they got a keratoconus. So in order to avoid that, I said, you know what, you get a PRK, topography guided, for myopia, and I do a cross-linking at the same time. Was not bad. At the 1-month follow-up, that lady was so happy. But then the action of the cross-linking started, making it flatter, and see, at 1 year she was a plus 0.5, and at 3 years she is a plus 2.5. So the cross-linking is something that goes on, and maybe is a negative side effect for the PRK. We have to have in mind that those two things may counteract. And also, should also know that it would not be right to show you only the good cases. That was a young man who got a cross-linking in Dresden by Dr. Kohlhaas, and then they came into Zurich and said, hey, you do have that topography-guided stuff. Can you do me a favor and just get rid of the residual astigmatism? I said, yeah, don't know. And then I agreed to get rid of the astigmatism here and limited to 60 microns. See, that is not often 4 weeks later. That cornea started to decompensate, the keratoconus really started, and I had to do a bulk. So whenever you risk something in order to regularize the cornea, and you don't cross-link it at the same time, you may fall into this trap and create a disaster. Let me go to cross-linking and LASIK. Every one of us knows those cases. That lady came in 2003, got LASIK for 5.5 diopters, actually in Munich, not in Zurich. The topography was good, and we calculate the residual stroma thickness of 315 microns. That was half a year later. A nice optical zone, tangential visualization with a little bit of red thing in the center, which might be due to a custom Q stuff or an undercorrection in the center. That increased, and that increased. And now it was very clear what it was. We did too much. That lady ended up with a keratectasia, which we called at that time in the Greek words iatrogenic keratectasia, made by the doctor, which Americans did not like at all. So, but the Americans were the ones to find out some scores, risk factors, like if the topography looks strange in terms of form frust, or the residual stroma is too thin, or the patients are too young, and if you do too much correction, then you are making out of that LASIK a kind of risk effect procedure. And that's why everybody was happy when they heard that we can do a LASIK extra. We create a cross-linking during LASIK by just putting one drop on the interface, put it back, do 1 minute of ultraviolet light, and then you get a stiff cornea. That's now how it works. Canelopoulos showed those data, and being honest, they were not really conclusive. With or without LASIK extra, there was not much difference. And so that's why we started to make a kind of safety study. We wanted to see whether this works out. We want to demonstrate that rapid cross-linking during LASIK prevents keratectasia. We know today that this disease occurs in 0.2%, 0.1 to 0.5% of the cases. And in order to prove that cross-linking and LASIK is better than LASIK alone, we need a 0 incidence in n prospective cases, so no keratectasia should occur in that series. Now, the mathematicians among us start to calculate about the number of patients that are necessary to prove that, and therefore you need Poisson's statistics, and it turns out that you need 7,500 eyes in one arm, which is totally ridiculous. You never get a study with 7,000 LASIKs, one eye with, and the other one with cross-linking, that one without cross-linking. That doesn't work out. And therefore, today we are very clear that we are not able to prove the efficacy. We are very clear that we cannot prove the efficiency or efficacy of that procedure, not clinically. So we have to think about doing it experimentally or doing it by plausible theoretical considerations, but clinically we cannot prove. But what we can prove is to prove the safety of the procedure, and that's what we did in Zurich. I'm just going over it. We had 70 eyes included because you need 66 in order to prove 5% safety. We had a 12-month follow-up, and times lost of best corrected visual acuity was the parameter. What we did is we just did a standard LASIK with a 90-micron flap, and then we had an irrigation of the interface with riboflavin for 2 minutes, stretching the flap and irradiating then the cornea, and then a bandage lens loaded. Next day, everybody looked hazy in the interface, and you can see it at the slit lamp already that there is a kind of inflammation in the interface, a DLK1 in nearly everyone. And if you look at the OCT, you see at day one, you see the interface, 1 month, 4 months, 8 months, and 1 year. It takes nearly a year to get rid of that kind of inflammation in the interface. And what we also saw is that the visual acuity took longer to come back. This is the standard LASIK, and this is the cross-linked LASIK. And you could see that in essence, we are coming close. At 3 months, we are close, but it takes longer to get a good visual acuity, which we would believe seeing the inflammation. The complication rate is less than we had no loss, but in 66 eyes, you can prove only that it's less than 5%. What we saw, erosions often in a quarter, Descemet's folds in 2/3 of the patients, DLK1 in half of the patients. And the nice thing is, after 1 year, that was the time that we had to wait until we do a relift, I could not lift the flap anymore. Relift, you can do up to 20 years after LASIK, but in those patients, I could not lift the flap. It was stuck, grown down, which is a good argument because we believe that then if the flap is more adhesive to the wound bed, then that makes the flap on a sudden contributes to the biomechanical stability. That's why we started in Harvard Medical School 2 years ago a study where we used rapid eyes and we did a LASIK and reattached the flap, dye in the stroma bed, irradiated it, and then we punched it out and did some shear measurements, just punching it out, and then you had the flap shifted on the wound bed, and that's how such an argument looks like, such a measurement looks like. You have the sandpaper on both sides, and then shift it, and you see it gives some resistance, and it breaks down, and those breaking point is very clear that it was pretty much better if you do riboflavin only and with no cross-linking, and you add the cross-linking in the interface, then you could see that you had a 2 times increase in adhesion of flap and wound bed. Now, experiments in rabbit eyes and rabbit corneas is one thing, clinic is another one, and so I said, hey, why don't we do it that way? We do that, and then let the rabbits live for about 3 months and then do it again, because that is much more conclusive. See, the 2 surgeons in Harvard Medical School That's me. And that is Theo, my youngest son. We did some staining. You see how yellow it is. And then we did the irradiation with the aiming beam. And 3 months after surgery, we could not shear it anymore. That damn flap was so adherent that it could not shear anymore. So we measured then what force it needs to peel it off. Sorry. Here we had a 3-fold increase in cohesion. So that after cross-linking in the interface, it's really stiffer. It really creates, it brings the flap back to its original underlying stroma, and the cohesion is stronger than before, than even non-operated. So in conclusion, cross-linking has become an integral part of refractive surgery. You may have recognized, maybe, I have in Zurich a low-budget center and a normal IROC center, and the complicated and difficult things, patients are coming to us, and there I'm doing cross-linking in nearly half of the cases. In the standard cross-link, in the standard low-budget refractive center, we do not cross-linking a lot. But nevertheless, whenever somebody comes in, has a form fruus keratokonus, or has a keratokonus, cross-linking has become an integral part of a refractive surgery approach. And the same is in Istanbul. Cross-linking is just belongs to our spectrum today in any refractive surgery. Transepithelial PRK, we call it trans-PRK, is a powerful mean to improve optics with and without cross-linking. Sometimes if a 65-year-old guy comes in with a keratoconus that has not changed for the last 20 years, I rather would go for a PRK without cross-linking. But usually the young guys, young people are coming in where you don't know whether it's stable or not. In those patients, I always would go for transepithelial plus cross-linking. And cross-linking during LASIK increases the flap adhesion and is considered safe. That is a safe procedure. You don't sacrifice anything. Whether this procedure, however, is, one T too much, is effective to prevent iatrogenic keratoectasia is unknown, and most probably will not be able to be proven. Thank you very much for your attention. Even? Now they are falling on me, killing me, trying to kill me.
Professor, I have 2 questions. The first, at the beginning, you started to speak about regression after cross-linking.
Yeah.
Then you say you do cross-linking with the surface ablation together. I just want to ask you, I know the studies about cross-linking with the same time or after 6 months more effective?
It was very clear that you would put that question on me because that is the only tricky part in that whole stuff.
No, yeah,
Nobody really knows what is better. I'm deciding it depending on the power that the patient brings in. If that patient comes in and wants to see better, and I cannot convince him that cross-linking alone is the good thing for him, then I'm doing it at the same time just to show the patient that I improved something. Because I'm sick and tired of that situation that I do a cross-linking. The patient comes in at 1 month, at 3 months, at 6 months, 9 months, at 1 year and say, hey, I still cannot see better. And then I have to convince the patient that I did something good for his eyes. Sick and tired.
I mean, if the patient form fruus keratokonus and young patients last 5 years, we do first cross-linking.
Yeah.
Then wait minimum 6 months. If we see any stabilization, then we do topo-guided treatment.
That is the right way to do it, no question.
Okay.
But sometimes they are pushing you.
Okay, I understand. About
especially
the
young ladies.
LASIK extra, that was a very big fight in our clinic. So when you compare LASIK ectasia incidence with the results of LASIK extra and the complications, and it's not reliable, what do you think? I mean, today we know how to read the topography, We don't see too much ectasia anymore.
That was my first question. When did you see the last keratoconus that you produced?
Maybe 10 years ago.
Years ago.
Yeah.
The same with me. I had just 3 months ago, a lady came in where I did a LASIK 5 or 6 years ago, and she developed slowly a keratoconus. But since we have topography, we have OCT, we have Scheimpflug photography, we are so good in prognosing difficult situations that this is not really worthwhile to go for it, because we know where the problems occur, and that's why the incidence drops down to 1 out of 10,000 meanwhile. And therefore, that LASIK extra, he invited me to give that talk. I wouldn't have started to talk about this anymore. But LASIK extra is, even if it's powerful, it's not needed today anymore, because we are so good in preventing keratoconus as clinicians.
Maybe it's very important to say to the patient after LASIK surgery, don't rub your eye.
Yeah.
It's very important.
Thank you very much. Another question?
Thank you for a fantastic presentation. Just one question. If you have a lady whose corneal thickness is 550 microns and 550.
50.
Yes,
Good.
like normal corneal thickness. She's -8 myopic, and she's planning to be pregnant in next 5 or 7 years or 10 years.
How old was she?
She's 25 or 30, and she's planning to stay pregnant in 5 to 10 years. Yeah. Would you prefer?
We call it the fine way, the polite ways. Her family planning is not yet finalized. Yeah.
Yeah. Okay. Without having her family planning finalized yet, would you do LASIK to her, or you would prefer to do something else, or you will postpone?
No. With 8 diopters, I would ask that lady just to continue with contact lenses if she can, and doing not a LASIK. In this case, that is a classical case for an ICL. Yeah, it's not only that she is in danger of creating an unstable cornea, but don't forget, if you do 8 diopters correction within 6.5 millimeter, at 1 year later it's at 6, the optical zone. At 2 years it's at 5.5. And if you only decentered it a little bit, she will complain about halos and phantom images. So from an optical point of view, the ICL is so much better compared to high correction of LASIK. That's why in Germany we have an upper limit right now at 8 diopters by law. You cannot do LASIK for more than 8 diopters, and we recommend in the Kommission refraktive chirurgie, recommend not to go beyond 6 diopters with LASIK, because there are better means to correct high myopia.
Even in thicker corneas, like 580?
It's independent of the cornea. It's the optic is just not good. And if you ask your patients with the 8 diopter corrections, they are of course happy that they finally don't need glasses. But if you ask them just to cover the non-dominant eye at night driving, they will tell you what they see. Halos, starburst like hell. They can accommodate, and most of those patients are still satisfied because they compare it to that how it was before. But that's not right, because they could have had all these benefits of having no glasses without starburst, without coma, without any kind of halos, using ICLs.
Thank you. You have been following your patients with cross-linking more than anyone here in the room, I'm sure of that. After following them now more than 15 years, or maybe even 2 decades, when you were mentioning that therapeutic effect of cross-linking, when that happens, is it always shifting toward hyperopic? As I saw, does it always shift from?
It's about 3% after crossing are non-responders. They just continue whatever you do. And those are the patients. I'm not doing a retreatment anymore. I tell them, we tried it once and then we do a DALK. And when I started in 2000, we didn't have DALK, and we had always to do a penetrating keratoplasty, which could end in a disaster, as we all know. But today, when we are doing DALK, After crossing, it's more difficult to do the dial, but we can offer somebody a real good alternative. So those are the 3%. And then we have this 5, maybe 8%, where it continues. And in those patients, after 10 years, they are coming in and ask for help. They get, because the cross-linking effect is so good, they get a trans-PRK with a large optical zone, and they are happy afterwards.
Thank you.
For the high myopia, I agree with Professor, but this also we don't do if it's higher than 7 diopter, even the cornea is thick, because these patients after 30 years, 20 years, they will come to you with the cataract. How you will recommend them multifocal intraocular lenses after if you operated?
I understand. I understand. Thank you.
Oh yeah. That is one of the side effects of refractive surgery. Anyway, I mean, I gave up in doing multifocal IOLs after refractive surgery. Now that generation where we did the PRKs in the 80s and early 90s are coming in for cataract surgery. In a few, I did that multifocal stuff. It did not work. They are not happy at all. Remember that the multifocal effect works in the way that you always have 2 images, one from the near, one from the far focus. Both are superimposed in the retina, and the brain selects the good one. So if any of those, both images are not good, the brain cannot select anymore, and therefore you don't get the multifocal effect, but all the side effects. And that's why we had at the last World Conference, we had a task force on the panel and said, guys after refractive surgery are not good candidates for multifocal IOLs. Yep.
Do you implant toric IOLs in keratoconic patients?
No.
Because a lot of people back in US, Western Europe are doing it, and there's no reasonable explanation for that.
No,
but they're still trying to explain that it's totally right thing to do.
But you know, even in America, you have dumb ophthalmologists and intelligent ones.
Thank you.